We will start the session from now on.
Hello and good morning and good evening, everyone. My name is Magara from the Niigata University, Japan. I'm chairing this session of the treatment 4. We have 5 presenters, including me. So let's start with my presentation. The title of the modulation of swelling-related motor evoked potentials induced by the interferential current stimulation.
The title of my study is Modulation of Swelling-Related Motor Evoked Potentials Induced by Interferential Current Stimulation. This is a disclosure of COI of my presentation. This study is partially supported by the research funding from the food care company. Interferential current stimulation, abbreviated as IFC stimulation, is used as one of the electrical stimulation therapy in rehabilitation. Gentle stim is a stimulus device which can deliver IFC sensory stimulation around the neck region. As the figure shows, 2 medium different frequency currents produce IFC beat wave, and IFC stimulation applied transcutaneously to neck region is considered to produce sensory stimulation in deeper tissue. And previous reports have revealed that immediate effect of increasing the number of swallow and shortening pharyngeal response time during the stimulation. And daily application of IFC stimulation can improve the cough reflex and nutritional status. One animal study using decelerated and paralyzed animal has demonstrated that IFC stimulation facilitated the swallowing reflex. However, it is not enough to understand the possible mechanisms, especially in the human. This study is aimed to investigate whether IFC stimulation can modulate the cortico-pharyngeal neural motor pathway in human. The material and method of the present study. 15 healthy adult volunteers participated in this study. Transcranial magnetic stimulation, abbreviated as TMS, was used to evaluate motor evoked potential, which is also abbreviated as MEP. The intraluminal catheter with bipolar electrode was inserted transnasally to detect pharyngeal MEP induced by the transcranial magnetic stimulation for the cortico-pharyngeal site. The change of pharyngeal MEP is considered as an excitability change to the cortico-pharyngeal neural motor pathway. This slide shows the outline of the experimental protocol. Each 15 volunteers came to the laboratory 2 times on separate days, and participants were inserted with the intraluminal catheter. Next, each participant underwent the baseline measurement of pharyngeal MEP. Subjects then received 15 minutes of IFC stimulation or sham stimulation in randomized order. Pharyngeal MEP were remeasured for up to 60 minutes following each stimulation. Analyzed data, amplitude and latency were measured as figure shows. Amplitude was defined peak difference, and the latency was the time between the TMS artifact and the onset of MEP. Average amplitude and latency were calculated and compared using repeated measure ANOVA with the factor of stimulation and time. P-values of less than 0.05 were taken as a statistical significance. Now I'm moving on to the result. During the IFC stimulation, we confirmed the IFC beat wave around the neck area recorded in the pharyngeal electrodes as a stimulation artifact, while no artifact signals was observed during the sham stimulation. If you take a look at the enlarged figure of IFC stimulation, the wave cycle of 20 millisecond period, which means a 15 Hz beat wave, was produced around the neck area during the stimulation. This is a summary of a statistical ANOVA analysis of changes of pharyngeal MEP in amplitude and latency. Two-way repeated measure ANOVA in amplitude shows a significant main effect of stimulation and time, but no interaction. No significant difference was found in terms of the latency. This is the main figure of the effect of IFC stimulation on amplitude change in pharyngeal MEP. The vertical axis shows a percentage change from the baseline of amplitude, and the horizontal axis is the time course every 15 minutes from the baseline up to the 60 minutes. Black circle and white square represent IFC and sham stimulation respectively. You can see that a pharyngeal MEP from the IFC stimulation shows significant amplitude changes compared with sham. Moreover, a significant increased amplitude is observed from 30 minutes up to 60 minutes following the IFC stimulation compared with sham, and at 45 minutes for the factor of time course. This slide shows the effect of IFC stimulation on the latency change. Vertical axis means the percentage change from the baseline of the latency, and horizontal axis means the time course from the baseline up to the 60 minutes following the stimulation. Black circle and white square represent the same as the previous figure. Although we can see that latency following the IFC stimulation tend to be shorter compared with the sham stimulation, no significant difference were observed in the latency across the experiment. Now, just to summarize my presentation. IFC stimulation can possibly induce the significant and sustained facilitatory modulation in pharyngeal cortical excitability. That is for my presentation. Thank you for your kind attention.
Okay, so now is the time to the question that and do you I didn't have any question Q&A, and is there any question for me? No. Okay. So I cannot ask myself. So okay, so let's move on to the next presenter. Okay. So the second presenter is Dr. Ortega. His presentation is the effect of the transcutaneous electrical stimulation in a chronic post-stroke patient with oropharyngeal dysphagia, 1 year result of a randomized controlled trial. Could you start?
Yes. Hello, my name is Omar Ortega. I am a postdoctoral researcher from Hospital de Mataró, and I would like to thank the scientific committee to give us this opportunity to present our results. So we can start with the presentation. Hello, my name is Omar Ortega, and I'm going to present you our study entitled Effects of Transcutaneous Electrical Stimulation in Chronic Post-Stroke Patients with Oropharyngeal Dysphagia, 1 year results of a randomized controlled trial. This study was sponsored by DJO Global. Oropharyngeal dysphagia is a condition recognized by the World Health Organization with a specific ICD code also for stroke, and it has a high incidence in the acute stroke phase of 47.5% and a high prevalence in the chronic stroke phase from 40 to 50%. In addition, it is related to severe complications such as prolonged hospitalization, institutionalization after discharge, poor functional capacity, nutritional and respiratory complications, and increased mortality. In addition, it is a neglected disease.
This slide shows the oropharyngeal swallow response in a post-stroke patient with oropharyngeal dysphagia, and as you will see in this video clip, there is an aspiration to the airway in the video fluoroscopy. We have seen in a previous study that a laryngeal vestibule closure time higher than 340 milliseconds predicts unsafe swallow with a high sensitivity and specificity, and in this study we found out that these patients were older, presented more severe strokes and neurotopographical strokes, and had poorer functional and nutritional status, and in addition they had a significant delay in the laryngeal vestibule closure time.
We have previously found that the sensory pathway is a key feature of the pathophysiology of post-stroke patients with oropharyngeal dysphagia, and we have found this with the evaluation of pharyngeal sensory evoked potentials to intrapharyngeal electrical stimulation.
In this particular study, we had 3 different populations: a group of healthy volunteers, a group of patients without dysphagia and stroke, and a group of patients with dysphagia and stroke. And what we found is that in patients with dysphagia, they present impaired conduction and cortical integration of pharyngeal sensory inputs. So we found that the sensory affection is a key feature of chronic post-stroke patients with dysphagia. This is a previous study with transcutaneous electrical stimulation in which we compared the effect of sensory versus motor electrical stimulation in a group of 20 post-stroke patients with oropharyngeal dysphagia. Mean age of the study population was 75 years old. They had all impaired safety of swallow according to video fluoroscopy, and treatment was applied during 10 days for 1 hour per day, and patients were randomized into the motor or sensorial stimulation groups. And we performed a video fluoroscopy pre and post treatment. We found in both groups of transcutaneous electrical stimulation a reduction in the prevalence of unsafe swallows, more than 60%, and also a decrease in the laryngeal vestibule closure time, meaning that these patients protected the airway faster. And we also found a decrease in the higher maximal vertical extension time. Regarding impaired efficacy of swallow, we only found significant improvements in the motor group with a reduction in the pharyngeal residue and also an increase in tongue strength. According to these previous results, we designed a new randomized clinical trial with this registry name in the clinicaltrials.gov. Main aims of this study were to assess the therapeutic effect of transcutaneous electrical stimulation at 2 levels of intensity, sensory or motor stimulation, in chronic post-stroke patients with dysphagia versus a control group with a classic compensatory treatment in a randomized controlled trial at 1 year follow-up. Secondary aims were to assess the effect of transcutaneous electrical stimulation on the biomechanics of the oropharyngeal swallow response. This slide shows the experimental design of the study. In the first day, we performed a screening visit to assess if the patient had dysphagia and impaired safety of swallow. We performed a video fluoroscopy that we used as a baseline evaluation, and then patients were randomized into the 3 groups. The treatment group intervention consisted of 15 sessions of 1 hour during 10 days, and then a post-intervention visit was performed. Then, after a period of 6 months follow-up, we performed another video fluoroscopy, and those patients that still presented impaired safety of swallow were retreated for 15 sessions during 10 days. Then a post-intervention visit video fluoroscopy was performed, and 6 months later we performed the final visit with another video fluoroscopy. As I have mentioned, we had 3 different groups: a control group with compensatory treatments based on fluid adaptation and solid adaptation and also posture recommendations, and a group of sensory electrical stimulation, and the final group with motor electrical stimulation. This slide shows the control compensatory treatment for the 3 groups, and it included adaptation of viscosity of fluids according to the fluoroscopy results, texture-modified diets, and also posture recommendations such as chin down. For the sensory electrical stimulation group, we use the thyrohyoid position with an intensity of 75% of the motor threshold that was determined previously by triplicate. The aim of this strategy is to increase the sensory input to the cortex in order to deliver a faster oropharyngeal swallow response and to protect the airway. This slide shows the neuromuscular electrical stimulation group. In this case, we use the suprahyoid position and with an intensity of 100% of the motor threshold that was determined previously. In this case, our aim is to cause nerve depolarization, causing muscular contraction. This slide shows the study flow chart and patients' characteristics. As you can see, we screened 204 patients and we included 90 of them. One of them withdrawn for randomization, and we had 29 in the control group, 30 in the sensory group, and 30 in the motor group. At the end of the study, at 1 year follow-up, we end up with 26 in the control group, 25 in the sensory group, and 26 in the motor group. Patients' characteristics were an age of 74 years old, 65% of them were men, they present impaired functional status with a Bartle of 73, risk of malnutrition according to the MNA, risk of dysphagia according to the E10, moderate stroke according to the NIHSS, and impaired functional capacity associated with stroke. Post-intervention 1 results are shown in this slide. We found that in patients of both transcutaneous electrical stimulation groups, there was an increase in the prevalence of safe swallows in video fluoroscopy and also a significant decrease in the penetration aspiration scale. Regarding the laryngeal vestibule closure time, so the oropharyngeal swallow response, we found a significant reduction in the sensory electrical stimulation group and in the motor group, but not in the control. And we found also a decrease in the upper esophageal sphincter opening time only in the sensory electrical stimulation. This slide shows the normalized response compared to the control group, and we found that both active stimulation groups, there was a reduction in the penetration aspiration scale, laryngeal vestibule closure time. There was an increase in the mean bolus velocity in the sensory group compared to the control group, and a decrease in the upper esophageal sphincter opening time in the sensory group. Regarding the needs of thickening agents, we found that in both sensory and motor electrical stimulation group, there was an increase in patients that could swallow liquid safely, while the control group remained stable over this treatment period. This slide shows the results at the end of the study, so at 1 year follow-up, and we found a significant improvement in safe swallows in both sensory and motor electrical stimulation group, so results were maintained after 1 year, and in addition we found significant reductions in the penetration aspiration scale in the 3 groups. However, in the control group, this improvement was not correlated with improvements on the oropharyngeal swallow response, as you will see later. This slide shows the results on the oropharyngeal swallow response, and we found a significant reduction in the laryngeal vestibule closure time in the sensory and in the motor group, while we found no improvements in the upper esophageal sphincter opening time at 1 year follow-up. Regarding the need of thickening agents at 1 year follow-up, we found a significant increase in the sensory and motor electrical stimulation groups in the percentage of patients that could swallow liquid safely, and also in the control group, but this increase was not statistically significant. Main conclusions of this study are that transcutaneous electrical stimulation is a safe and effective therapy for post-stroke oropharyngeal dysphagia, as we did not find any severe adverse event related to these therapies, that both sensory and motor electrical stimulation greatly improve the safety of swallow and the biomechanics of the swallow response, with a reduction in the laryngeal vestibule closure time, and also they reduce the need for thickening agents. Finally, we found that the therapeutic effect that was observed after the first intervention was maintained after 1 year follow-up. Thank you.
Okay, thank you, Dr. Ortega. Now is the time to question and answer. There is no question and answer in the web, on the web. Oh, Dr. Patel, do you have any question? Okay. So from me, I would like to clarify the sensory stimulation because the neck area is innerved with the trigeminal cranial nerve. So how do you think the mechanism of the improvement of the swallowing function following the trigeminal stimulation?
Okay, so with this specific position, the thyrohyoid position, our aim was to increase the sensory input in order to trigger a faster oropharyngeal swallow response by means of creating neuroplasticity. So our aim was to stimulate the glossopharyngeal nerve and the superior laryngeal nerve through this kind of stimulation. In the past, we have also had good results with this kind of position, and this was the main aim or mechanism of action. However, in this study, we have not evaluated neurophysiological measures such as sensory or motor evoked potentials, but this is a target for the future to know the exact mechanism of action of this kind of strategy.
Right. Okay. So any other question from the web? No. So can I ask the do you think that is it better to combine with motor training with stimulation? So did you perform any motor training during the stimulation?
Mm-hmm. No, in this study, the stimulation was given alone because we want to assess the effect of the treatment alone. But I think that if we combine this strategy with exercises or motor stimulation, maybe the results will improve. Yeah.
Okay. Any other question for him? We have more time. So, did you stratify depending on the infracture area of the stroke?
No, in this case, we did not separate the groups of patients according to the stroke characteristics, but the majority of our patients were unihemispheric strokes, the majority supratentorial, but in this case, we did not have the opportunity to spare the groups because the number of patients was reduced and we did not did this.
Right, so is there any brainstem stroke patient in your study?
Brainstem, no.
Only the cerebral area. Okay. Okay, it's time to move on the next speaker. Thank you, Dr. Ortega.
Thank you.
Okay, the third speaker, the title of the third speaker is the effect of pharyngeal electrical and transcranial direct current stimulation and the cortical activation during the swallowing and pneumatic stimulation after induction of the virtual pharyngeal region, presented by the Dr. Muri.
Thank you very much. Yeah, that's right. Today I'm going to present that. Thank you so much. Please start the video. Hello everyone, this is Paul Muller from Münster University speaking. Thank you very much for having me at the WDS this year, and thank you to the organizing committee for all the work you put into this. I'd like to talk about the effects of pharyngeal electrical and transcranial direct current stimulation or cortical activation during swallowing and pneumatic stimulation after induction of a virtual pharyngeal lesion. These are my disclosures, and I'd like to start with these figures. As you are all very much aware, we need a constant sensory feedback from the pharynx for safe swallowing. If we are impaired in the pharynx, we have an increased risk of aspiration, and in these studies shown here, we saw that during swallowing, we have a relatively broad activation on the cortical level. These are pictures from the MEG, the magnetoencephalography, during swallowing, and after induction of topical anesthesia against the pharynx using lidocaine spray, we see a downregulation of these areas that were activated before during swallowing. And here we see similar effects using topical anesthesia after the application of an air pulse stimulation, which also leads to activation in areas pericentrally that are very similar to the ones that we see during swallowing, and those are downregulated similarly. During the last couple of years, a number of studies show that PES, the pharyngeal electrical stimulation, as well as TDCS, the transcranial direct current stimulation, are able to improve swallowing function, particularly in patients post-stroke. One of these, the PES, is a peripheral approach. We use electrodes placed in the pharynx to applicate an electric current, whereas using TDCS we have a central approach where a current is directed to cortical areas of the brain to modulate the activation of these areas. Since those two techniques have shown some success leading to an improvement of swallowing function, we were wondering whether one of the mode of actions that are the reason for this improvement may be an improvement of the pharyngeal hyperesthesia as part of dysphagia. So our research question was, are one of those techniques or both able to reverse the effects of pharyngeal hyperesthesia as a relevant contributor to pharyngeal dysphagia? What we did is we had a sham-controlled randomized design with 10 healthy participants, of whom 5 were female. The age was approximately 29 years old. We looked at the cortical activation during swallowing, as well as during pharyngeal pneumatic stimulation. We used lidocaine spray against the pharynx to induce a virtual peripheral lesion, as shown in the figures before. Again, we used a 256 sensor MEG by CTF Systems and had standard parameters on the PES and TDCS parameters that had previously been shown to be successful in stroke patients. We used a nodal stimulation, 1.5 milliamp over 10 minutes over the right pharyngeal motor cortex placed. So what we did is we used the lidocaine spray to induce a virtual peripheral lesion, waited for 15 minutes, and then did a baseline MEG measurement of either swallowing or pneumatic stimulation. Then again, we used topical anesthesia, had an intervention for 10 minutes, either TDCS or PES, had 5 minutes to place the participant in the MEG once more, and then we could do another 15-minute run of MEG either during swallowing or pneumatic stimulation. What you can see here is we had condition A, which was swallowing, and TDCS as an intervention. This was either real TDCS or sham condition using TDCS. Here we did the similar thing with pneumatic stimulation and TDCS. Condition C was swallowing and PES, and condition D was pneumatic stimulation and PES. Again, for each of these conditions we had a sham and a real intervention group. This is what we found in the alpha band using PES and swallowing condition. We saw an upregulation of activation, an increase of activation in areas that are known to be involved in swallowing, not only in the sensory function but also in the motor function, in the alpha frequency band, which has previously been shown to be relevant for swallowing. Similarly, we found an increase of activation in the low gamma frequency band here. Considering the pneumatic stimulation, we saw an increase of activation only in the high gamma band following PES, but that was significant. And again, those were areas that we know are involved in swallowing. High gamma is known to be involved in sensory processing, so this would fit just fine. And here we see the significant clusters of differences between the sham and the real. conditions, and what we see are areas that we know are involved in the process of swallowing and the sensory function during swallowing, explaining that PES may at least partly contribute to an improvement of sensory feedback. Whereas TDCS would show no such results, we found no significant clusters when comparing the differences of sham and real intervention using TDCS during swallowing, neither during pharyngeal pneumatic stimulation or in one of the sham conditions. To sum up, PES showed to be able to partly remove the effects of a virtual sensory lesion of the pharynx and cortical activation during swallowing and following sensory stimulation of the pharynx. PES activates multiple regions in the widely distributed cortical swallowing network, not only sensory areas, but also areas involved in the motor function. TDCS showed no effects on the downregulated cortical activation following lidocaine application. And these results may have implications for therapeutic decisions depending on the nature of dysphagia in the clinical context. It is possible that in the future, maybe patients with more impairment of the pharyngeal sensory feedback may have a larger benefit from PES. So this could be one of the implications. Of course, there are a number of limitations. We had only a relatively small number of participants. We could only look at the cortical activation that is a limitation of the MEG in principle, and we saw stimulation parameters and location that may not have been optimal, particularly for the TDCS, since we targeted the motor areas of the pharynx. And maybe another target and other stimulation parameters may be more optimal, but that needs to be investigated in future studies. Thank you very much.
Thank you, Dr. Miure. And now is the time to the Q&A. Is there any question for him? So I would like to clarify that you used TDS stimulation for the right hemisphere.
Yes.
Why did you select the right for the another stimulation?
Since it is difficult to find an optimal target of TDCS considering the sensory function of the pharynx, we used parameters that had previously been shown to be effective in stroke patients. It would be of interest to see if other targets are more suitable. But in this context, we used parameters that had previously been used on stroke patients and showed to be effective. And so we figured if the TDCS has shown to be effective before, maybe it might be partly due to also effects on the sensory cortical network, and at least in these healthy participants, we could not reproduce this. Yeah.
Right. Okay. So any other question for him? So can I ask one more?
Sure.
And did you confirm that stimulation side of the PES in the pharynx, right? Discriminated the side of stimulation side of the PES.
No, we had a measurement where we saw that we had a right placement, and we would then upregulate the stimulation intensity so to a level that it was acceptable to the participant individually, but we would not have a chance to do FEES, for example, to see on which side it was placed.
Do you think the position of the PS is, should affect the brain activity? Do you think?
On the placement, well, as the pharynx is mainly with regard to sensory function represented bilaterally, I assume that the effect is not is not large, at least.
Right. Is there any question for him? Okay, so can I ask one more question?
Sure.
Did you confirm the effect of the local anesthesia in the pharynx? And did you confirm the kind of the sensory check the sensory threshold or not?
Yeah, we would do that in the PES condition.
Mm-hmm.
The idea was we had a baseline measurement without the lidocaine application, would see where we had a threshold, and then we would need an increase of this threshold after application of lidocaine of at least 30%. And
30%, all right.
That's the way we could confirm that.
Okay. Any other questions? So now is the time to move to the next speaker. Thank you,
Thank
Dr.
you so much.
Sorry, Mure, sorry.
Fine.
Sorry.
That's fine.
Okay, so let's move to the next speaker. The third presentation is surface electromyography biofeedback to improve the swallowing function in person with dysphagia and idiopathic Parkinson disease intervention study presented by Dr. Patel.
Yes.
Can you start?
Yeah, thank you. I'm pleased to present my study, and I completed my PhD at the Trinity College of Dublin, but I'm working in Venice at the Clinical and Civil Hospital. So could you please put my video? I'm Ari Bettel, and I would like to thank the Second World Dysphagia Summit for the opportunity to present my study, SUFI Electromyography Biofeedback to Improve Swallowing Function in Person with Dysphagia and Parkinson Disease, an intervention study. This study was part of my PhD carried out under the supervision of Dr. Margaret Walsh at the Trinity College of Dublin. I have no financial disclosure or conflict of interest. I want to start describing why biofeedback is important. It's well documented that cue and feedback activate directly the cortex, bypassing the basal ganglia, which are damaged in this population. In addition, biofeedback increases salience specificity during the first phases of learning swallowing skill, as described by Dr. Akabi and Bornip. We recently carried out a systematic review which showed that visual biofeedback a positive effect on swallowing, especially in increasing the quality of life, mostly during skill intervention. The majority of this study used biofeedback, surf-EMG biofeedback, which consists in surf electrodes attached at the submental muscle, and there is a positive correlation between the maximum peak of surfy waveform and the maximum hyoid excursion. However, the main limit is that activation could be triggered also during a swallowing task. So this rationale was the basis of this feasibility study. We want to look at if this intervention will decrease the pharyngeal residue and also decrease the penetration aspiration events, improve the method of oral intake, and also will reduce the self-perception of drooling in this population. In addition, if this intervention will improve the quality of life, and if there are any change, will maintain at the 3 months follow-up assessment. In addition, because this is a feasibility study, we want to look if there were any adverse events and if this treatment was acceptable to people, and also feedback from the participants. Methods. We include people with idiopathic Parkinson disease. Oropharyngeal should be conferred by instrument examination. Absent of really severe dysphagia tube feeding patients. Absent also Parkinsonians and DBS, and also cognitive impairment and ability to provide autonomous consent. We screen